Bismillahirrahmanirrahim. So I have already gone through the headaches. So let's quickly revise all of the types of headache. Okay. So how we're going to differentiate these headaches? Right. So we have divided the headache into acute, subacute, and chronic headaches. Right. So in acute we have got the single episode and recurrent episodes. Right. So for single episode, if we talk about infection, so there's meningoencephalitis can cause acute single episode of headache. Then we have got cerebral malaria that is going to cause the acute single episode of headache. Then we have got the trauma, right? In trauma we have got the post concussion extradural and subdural hematoma. All right, and the next thing is third thing is subarachnoid hemorrhage and venous sinus thrombosis and acute sinusitis and rhinitis. So these are the causes of acute single episode. So let me discuss them one by one, briefly discuss. Okay, I'm gonna discuss these very briefly. So let's talk about infections. So in infections I have made a video on that. So right, so meningoencephalitis is one of the cause of acute single episode. If we talk about meningoencephalitis, so we had divided that into bacterial, right? It was like bacterial. Then we have got the viral causes. Then we also studied about the fungal and parasitic causes of that, right? So in bacterial we know that there is ABM, acute bacterial meningitis, and then we have got chronic bacterial meningitis that is caused by tuberculosis, right? So acute bacterial meningitis, there according to age group I have divided that, like in neonates there was a Bell pneumonic for that, and for preschool age there was in H influenza, which was a leading cause. And then we have got the 5 to 60 years in 5 to 60 years of age group, we have got pneumococcus pneumococcus and meningococcus that are leading cause of the acute bacterial meningitis, right? So the next thing was the streptococcus pneumoniae. There was pneumococcus, and that was leading cause of meningitis in elderly people, right? So we have talked about different types of meningitis. So if we find a meningitic triad like that, if we find patient is having fever, right, patient is having neck stiffness, right, and patient is having outer level of consciousness or headache, right? So this is meningitic triad, right? So if there is no fever, patient is just having headache and neck stiffness, we're gonna think about the patient is having subarachnoid hemorrhage. So we're gonna think about the subarachnoid hemorrhage, right? So we have discussed the syndrome related to that. There is SIADH, syndrome of inappropriate ADH release, that we can see in any type of CNS infection that can cause SIADH, right? There will be hyponatremia. And we have also talked about meningococcemia that can lead to DIC and Waterhouse-Friderichsen syndrome. So in SIADH, serum sodium will be because of there will be euvolumic hyponatremia in these patients, right? There will be dilution hyponatremia, right? And if we talk about Waterhouse-Friderichsen syndrome, so there will be, as we know that when there is deficiency of aldosterone, so potassium will be high and sodium will be low, right? So that's how we're gonna differentiate between these two conditions, right? Okay, so then we talked about treatment part of the meningitis, and there we discuss about that we have to give the injection ceftriaxone, 2 gram IV BD for that, to cover the meningococcal bacteria and pneumococcus bacteria. For elderly people, for more than those patients having age more than 55, so we have to add ampicillin with that 2 gram IV QID, right? If patient was having fever, these symptoms are in sudden onset, we're gonna think about the patient is having acute bacterial meningitis. If these symptoms are in serious onset, right, so we're gonna think about patient is having tuberculous meningitis, and they should be also constitutional symptoms, like patient who should be having weight loss, night sweats, right? So, and dry cough, and patient might have the history with the tuberculous bacteria. There might be family history for that, right? So for viral encephalitis, viral meningoencephalitis, leading cause was enteroviruses, right? And another one was herpes simplex virus 1 and 2, basically 2. So this mostly affects the temporal lobe. So we're going to see PLED, periodic lateralized epileptiform discharges on EEG, right? And there will be low grade fever in these patients, history of low grade fever, right? And the symptoms occur suddenly. So we need to do the lumbar puncture, right? And after interpreting the lumbar puncture, we're gonna initiate the treatment for viral causes, right? So that's what we discussed. That's what we covered most of the um, causes of meningoencephalitis in that part. And we also studied that for TBM we need to give the steroids along with ATT, right? Okay, so that's all about the brief discussion regarding meningoencephalitis, right? So the next thing is the trauma, right? So cerebral malaria is left, so we're going to discuss it separately, okay? Right. So in trauma, we have got the post concussion headache. Right. We if patient comes with the headache after patient comes with the history of RTA, or comes with the history of fall with the head injury, and there will be headache, and this will not be relieved by routine NSAIDs. Right. So non-responsive to routine analgesics. So this will be post-traumatic concussion. So what we need to give these patients, we can give the carbamazepine, phenytoin, and carbapentins, right? So generally it takes 2 weeks to settle, right? So this was the post-concussion headache. Right. The next thing is extradural hematoma. We're gonna compare these three things here, okay? Extradural, subdural, and subarachnoid hemorrhage. So in extradural hematoma, this will be between skull and dura mater. So this is dura mater and this is skull cavity. So there will be an artery that is called as middle meningeal artery that is going to rupture. So this is going to cause the lens shaped hematoma, right? So there will be lens shaped hematoma in that. So patient might be having lucid interval, right? So we also studied that if any one of those three findings were there, like patients having fluctuating level of consciousness, right? Patient is having consciousness that is very slow to improve, and patient is having lucid intervals. So we're going to think about the patient is having extradural hematoma, right? So there will be violent history, like patient will be having violent accident, right? For subdural hematoma, we can divide that in acute and chronic form, right? So in chronic form, there might be no history, right? In acute form, there will be history, and the severity of injury will be less, right? So in this was the skull, and this was the dura mater, and then we have got the arachnoid mater. So between dura and arachnoid, if this hematoma is formed, so we call that, if this crescent shaped and hematoma is formed, so we're going to call that subdural hematoma, right? And this is mostly because of the bridging vein rupture. So bridging veins rupture in this case, right? So in subarachnoid hemorrhage, mostly this is because of the berry aneurysm rupture. So we have studied about that between junction of anterior communicating artery and anterior cerebral artery, right? So this is the most common point of the berry aneurysm. So it can rupture and we can see the fast localizing sign in these patients. So what we need to do in these for the management of these patients, we have to lower the ICP, intracranial pressure, by giving mannitol, right? So we need to give the we have to prevent the Cushing ulcers in these patients, and we have to control the blood pressure, right? And have to decrease the Okay, so it decreases intracranial pressure, right? And this was the general treatment, and we also need to give the, if it is subarachnoid hemorrhage, so we have to add the calcium channel blockers, right? We have to add nimodipine, right? 60 mg QID, right? For ex- and for extradural hematoma, it was the, Burhole craniotomy. We need to do that. We can also go for hemicranectomy, and for subdural hematoma, treatment is same, right? Burhole craniotomy, right? That depends patient is having acute or chronic, right? So right. So I think I have covered most of the part of the treatment in these patients. And for subarachnoid hemorrhage, we need to get the CT angiogram, right? If there is any, perianeurysm left, so we have to check the size of that. If it is less than 7 mm, so we need to just conservatively manage that. If it is more than 7 mm, we need to go for the clipping and coiling of these aneurysms, right? Okay, so the next thing is venous sinus thrombosis. So let me erase this data from here. Okay, so in venous sinus thrombosis, there will be thrombosis of the cortical venous sinuses, right? We have got like superior sagittal sinus, right? Then we have got inferior sagittal sinus. Then they meet with one another, and there will be, transverse sinus like that. So if there is thrombosis in these sinuses, so what will happen, we find mostly small hemorrhages and edema with that in these patients. Mostly it happens after pregnancy, right? So this is the only condition where we see the hemorrhages, and we need to give the anticoagulation to these patients, right? So patient will be in altered level of consciousness. The patient will be having altered state, right? So I think that's enough about the venous sinus thrombosis. So we need to treat, we have to give the anticoagulation to these patients, and we have to give the remaining conservative management, like we have to lower down the raised ICP. Okay, the next thing is the acute sinusitis and rhinitis. So we just need to give the anti-allergic, and we need to give the um, uh, antibiotics to these patients. So that's all about the acute single episode headaches, right? So we have covered infection part, covered the traumatic part, and we have covered the subarachnoid hemorrhage, venous sinus thrombosis, and acute sinusitis. So let's talk about acute recurrent headaches. In the first headache, first subheading is the migraine, right? So let's talk about. Let me erase this data from here. Okay. All right. So let's talk about migraine. So patient will be having acute recurrent headaches. So when we talked about migraine, so I said that migraine is very miserable condition, right? So there was two theories related with that. One was the vascular theory, and another one was the neurogenic theory. Okay, right? So there was the intracranial vasoconstriction, followed by extracranial vasodilation, right? So with this vasodilation actually irritates the dura mater, so the patient will be having pulsatile headache, right? Unilateral pulsatile headache. So when patient have the intracranial vasoconstriction, so patient will be having aura like symptoms. Okay, in aura there was visual hallucinations and distortion and lines, dots, zigzag. There might be complete chaos, right? Patient might feel abnormal sensations that are called paresthesias, right? And after that, patient start having headache, and was almost this headache was followed by aura, right? So patient might have aura. This was typical migraine case. So aura, then patient had headache, and this headache remained for 4 to 72 hours, like 3 days, right? So it's a long time. So patient may miss the working days, right? In headache, patient will have be might have the nausea, vomiting, right, photophobia and phonophobia, right. And these patients usually they take some NSAIDs, they take paracetamol, and they turn off the lights and turn off the musics and sounds, and then they have some rest, and then this headache goes away, right. So and it was more common in females than males, right. So then we talked about the types of headache, right. Sorry, the types of migraine. There was atypical migraine, right. Typical migraine, so it has got the one was the migraine without aura. So I just write without like that. This is actually without, okay, right. So without aura, so some patients have migraine without aura. And the second type was the ophthalmoplegic migraine, in which there was the involvement of the third cranial nerve. And the third thing was the familial hemiplegic migraine, right. In that type, there was transient hemiplegia in those patients. There was migraine, and then there was transient hemiplegia with that. And the last type was the basilar artery migraine. Basilar artery migraine, in these patients there was the migraine with cerebellar signs, right. Right, so that's all about the migraine. So we just discussed the treatment part here. For acute attack, we used to give the NSAIDs, right, and paracetamol for that. And for prophylaxis, okay, so we need to give the propranolol to these patients, right. And also we talked about that migraine improves in pregnancy, right. So I think I have covered most of the part of that. So all right, so let me just mention duration here, okay. So one episode remained for 4 to 72 hours, right. So there should be aura with that. That was called typical migraine. So let's talk about cluster headache, right. So cluster headache, we know that it is more common in males than females, right. So in what happens in cluster headache. So why we call this as a cluster headache? Because attacks were clustered in time, right. So duration of attack was almost 4 to 12 weeks. That's mean is 8 weeks, right. So if we say that just this is Jan, Feb, March, April, like that, May, June, okay. So attacks might be clustered in one time, like patient might have the attacks for 2 months, then January and Feb, then whole year was without any headache, right. So that's why we call it as cluster headache. So attacks are actually clustered in one time. So these attacks remain for almost 4 to 12 weeks, that is almost 8 weeks, right. So it remains for almost 8 weeks, right. So and duration of single attack of episode was almost 15 to just to say that 30 minutes to 3 hours, okay. Just to remember this thing, that duration of single episode was 30 to 3 hours. And there was 1 to 8 attacks per day, right. So just say if patient is having um, 5 attacks per day, so one attack remain for 3 hours, so his 15 hours will be lost, right. So every day he's having headache for 15 hours for 2 months, so it is very miserable condition, like that of migraine, right. So clustered, these attacks are clustered in one time. And we also studied about that, just like migraine, there was two theories related with that, and one gene related with that. And in the clustered headache, the main problem was the extracranial vasoconstriction followed by vasodilation, right. Like superficial temporal artery, there was initially vasoconstriction followed by vasodilation. When there is vasodilation, the patient feel unilateral throbbing pain, and along with that patient might have epiphora, like okay. So in the patients with cluster headache, there was some severe sudden onset severe pain in one eye, severe pain in one eye, and then it was like bloodshot, right? It was like bloodshot. So patient will be having unilateral throbbing headache. So we need to differentiate it from another condition that is called as acute angle closure glaucoma, right? So I have mentioned this in my previous video that in angle closure glaucoma there will be history of like patient might be watching a movie in cinema hall, so it gets precipitated by dark, right? So there will be actually pupillodilation, and there'll be no history of cluster headache, like there'll be no history of attacks in clusters, right? So that's how we're going to differentiate with that. So patient will be having recurrent attacks of this, and we need to measure the intraocular pressure, and we have to do the third clock iridotomy hole in these patients, right? So we need to create a hole in the iris so that it can easily get rent. So right, so we have covered also narrow angle glaucoma with this, right? So for cluster headache, the treatment was 100% oxygen, right? So we have to give 100%. Somehow it improve the symptoms, and we have to give injection sumatriptan to these patients. Sumatriptan 6 mg subcut, right? So if we give this, then symptoms get relief. And for prophylaxis, we can give these patients verapamil, right? So calcium channel blocker. So in migraine part, for acute attack we have to give paracetamol and NSAIDs, and for prophylaxis we have to give the propranolol, right? So, but here the calcium channel blocker, we have to give the calcium channel blocker, right? So that's all about the cluster headache. So the next thing is the alright, so the next thing is trigeminal neuralgia. So let me erase this data. Alright, so cluster headache, just wanna mention the duration here, that patient might have 1 to 8 attacks per day, right? And each attack will remain for 30 minutes to 3 hours, right? So total duration will be like 8 weeks, just say 2 months. Okay, so that's all about the cluster headache and migraine. So trigeminal neuralgia. For trigeminal neuralgia, 80% there was no cause of that, and for it was rest of the 20%, it was associated with AV malformation, right? It was associated with some tumor in the brain, and it was associated with meningitis. So female have more risk than male. So it was like intense shooting pain in territory of trigeminal nerve, right? So a patient might have pain in ophthalmic devian, maxillary or mandibular devian. So patient will be having severe lancinating, like cutting pain, shooting pain, stabbing pain that remains for seconds. So it just remains for seconds, right? So we have to get the MRI brain done to see any malformation, aneurysms, and tumors, right? So treatment is the carbamazepine. So we have to give the patients carbamazepine prophylactically, and second line was the gabapentin and phenytoin, right? Right, so recurrent meningitis, we have discussed this in the meningitis part, that those patients having the fracture of the base of the skull, they might get the recurrent meningitis, right? So I have covered the acute part here, acute headaches, acute recurrent episodes, and acute single episode. The next thing is the giant cell arteritis, right? So the next in line is the subacute headache, and only one type is the giant cell arteritis, also called as temporal arteritis. So giant cell arteritis was actually the granulomatous inflammation of the branches of the carotid artery. Sometimes aorta was involved, so that's why we call that as giant cell arteritis. So we have to consider any patient who is having headache for few weeks, right? And patient age is more than 55, so we have to consider in those patients that he might have the giant cell arteritis. So the external carotid artery is involved in this patient. So it is also possible that patient might have the internal carotid artery branches got involved. So first branch of the internal carotid artery, that is ophthalmic artery, when it get involved, so there is increased risk of blindness in these patients. So any patient that is having headache for a few weeks, right, and having scalp tenderness like while combing hair, and there is transient loss of vision, and there is sometimes there is jaw claudication. So we need to consider these patients is having the giant cell arteritis. And we also discussed about the PMR, that was polymyalgia rheumatica, one of the variant of giant cell arteritis, right? So it was, if age is more than 70 and female to male ratio is 2:1, right? So patient is having same complaint like scalp tenderness and having the jaw claudication, along with patient is having the proximal joints, uh, pain in proximal joints, like patient is having the morning stiffness, and patient is having difficulty in climbing upstairs, and patient is having the combing difficulty in combing because of the scalp tenderness, right? So for joint cell arteritis, we can go for the we have to investigation, like we can go for the ESR, right, if it is raised. So the second thing is that we can start the pulse steroid therapy, right? And the third thing is we can go for the segmental biopsy of the temporal artery, right? Okay, for PMR, polymyalgia rheumatica, we have to start the oral prednisone 5 mg per kg, right? So that's all about the giant cell arteritis and polymyalgia rheumatica, the variant of that, right? Okay. Okay, in the chronic headache, so all right, so in the chronic headache, the if headache remains for more than 15 days a month, and it remains for 3 months, more than 3 months, so we need to label these patients as chronic headache, right? So in the chronic headache, we have got first type, that is called a stress headache, also called as tension headache. Then we have got the space occupying lesion. So I have discussed about the cysticercosis and cerebral tumors, right? And okay, so medication misuse headache. So if patient is consuming opioids for a long period of time, so patient might get the headache. And if we withdraw the culprit drug, so patient the headache goes away. And the last thing is the pseudotumor cerebri. So let's briefly discuss one by one all of these. So for the tension headache, so patient will be having like a tight band around the head, right? So patient will be having like tight band around the head, right? So it will be bilateral non-pulsatile headache. So if we get the CT MRI, so diagnosis will be clinical and CT will be normal. And we have to just if patient is having triggers was like anxiety, emotion, stress, and overwork, so we need to ask the patient for breathing exercises, and we need to get the massage of head done. And also we can give these patients NSAIDs, right? And if patient is having anxiety problems, so we can give the patients anxiolytics, right? Okay. In space occupying lesion, so I have talked about neurocysticercosis, right? So for neurocystic psychosis, there will be some calcified lesions in the brain, right, like that. So for treatment part, so we have to give the steroids first, right, when inflammation settles down. So we're gonna give these patients albendazole. Okay. And for the tumors, cerebral tumors, so I have talked about that too. So cerebral tumors, so most common cerebral tumor was metastasis from the mostly lungs, right. So I have showed the image from the Davidson. Okay, so most common was the metastasis from lungs, like small cell carcinoma of lung, right, that is also called as old cell carcinoma. And the next one was the CA breast, right. So we just have to give these patients, we need to treat conservatively. We have to go for the chemotherapy, and we can also go for the surgical section, right. That depends, patient is having meningioma, craniopharyngioma, and different types of tumor. I have discussed all of them mostly, right. So the next thing is the medication misuse headache. So I just when an episodic headache becomes a daily headache, right, patient actually abuse the narcotics, triptans and opioids. So if we withdraw the culprit drug, so this patient's headache goes away. The last thing was the pseudotumor cerebri. So let me erase all of this from here. Okay. The next thing is the pseudotumor cerebri. If we do the CT imaging in these patients, we're not going to find anything. Okay, CT will be normal, so patient presents like patient is having tumor. But if we get the CT done, if we get the imaging done, CT MRI done, so it will be normal, right. And if we get the fundus examination done, so there will be papilledema, right. So in these patients these were the mostly obese and young patients that present with a chronic headache, and there will be bilateral papilledema, right. And it has some association, it has association with Cushing syndrome, hypo and hyperthyroidism, right, polycythemia vera, and hypoparathyroidism, right. So it has got association with these, right. And some patients have, like CRF patients, chronic renal failure, and SLE patient, it has association with the pseudotumor cerebri and hypervitaminosis A, right. And in the drug part, for if we get the investigations like CT, MRI, it will be normal. So for treatment part, so we have to just ask the patient for the we have to get the dietary modifications. We have to get the ask the patient for the weight loss, right. And we can give the patients diuretics. Okay. And sometime there is 10% loss in these patients, so we can go for optic nerve fenestration in these patients, right. So I think I have covered the major topics of headache. So there was another classification, that was primary headache and secondary headache, right. So most common cause of headache was the tension headache, and most common cause of primary headache was also tension headache, and the second cause is the tumors, secondary cause is the tumor. So I think I have covered the most of the types of headache. So that's all about the headaches, right. Okay, thanks for watching. So see you in the next video.